Good morning. Can we start? Yeah. All right. So this is the session on childhood glaucoma from the Indian Pediatric Glaucoma Society. So today we have Dr. Mandal as the chairperson, Vinay as the co-chair, Sunita and Manju as conveners, and I will be moderating the session. So we'll start off with the first program, the definitions and diagnosis of glaucoma. To begin with, what would make you diagnose glaucoma in a child? This will be clarified to us by Dr. Vinay. Vinay, please.
And yeah, so I think making a diagnosis in a child has been very clearly sorted out by the International Classification for Childhood Glaucoma, which says that any intraocular pressure greater than 21 millimeters of mercury, possibly on two separate occasions, with an axial length that is progressively myopic for that particular age, or corneal diameters which are greater than 11 millimeters in the presence of HARP striae at birth, or greater than 12 at less than 1 year, or greater than 13 millimeters at any age, or there could be a progressive increase in the CDR or greater than 0.2 CDR difference between the two eyes, or there could be the presence of a classic glaucomatous optic neuropathy in the presence of focal thinning of the rim. And of course, if the child is old enough, you can get a visual field done to look for visual field effects. So if any of these two are present, then classically it is a case of a childhood glaucoma. So this particular diagnosis is sort of well respected by the pediatric glaucoma specialists all over the world. But if you are suspecting a child with glaucoma, then any of one of these need to be present. That means an intraocular pressure greater than 21 millimeters of mercury, an axial length which is increased for that particular age in the setting of a normal intraocular pressure, or a cornea which is showing an increased corneal diameter in the presence of a normal intraocular pressure, or a disc which is suspicious. Of course, visual fields are generally not done for children if the child is less than 8 years of age. So since pediatric glaucoma comes in a lot of forms, and it is sometimes difficult to say what is glaucoma and what is not glaucoma, for which you need an examination under anesthesia, in which case you have to be very clear that you have to tell the parents exactly what you are looking for, what has to be, what you're going to do ultimately with the child during this examination. You have to take a proper consent. It could just be an NLD block that you are dealing with. So that again has to be explained to the parents, that everything will be looked for in your child during this examination. And everything should be available in the OT. So basically, it has to be done in specialized centers which are dealing with pediatric glaucomas, where everything is available in the OT, including a tonometer and sometimes an ultrasound biomicroscope and an ultrasound of the posterior segment. So the sequence of examination and anesthesia before you diagnose it is the one that we follow in our center, is that we do an anterior segment examination, we measure the corneal diameter, and it is after that that we measure the intraocular pressure. That is when the effect of anesthesia is more or less stabilized. After this, we do things like refraction, fundus evaluation, and an axial length measurement. So this is what we follow at RP Center. What does anesthesia do to intraocular pressure? It does reduce the intraocular pressure by 3 to 4 millimeters of mercury, and that has to be understood when you are measuring the intraocular pressure, especially under the anesthetist that we use, which is sevoflurane or isoflurane in most of the centers. Then there are normograms by which you can compare the axial length of that child's eye with that of a normal, and this has to be well understood, because you see, if in a newborn the axial length is 19 or 19.5, then it raises a suspicion that there's something going on there. So therefore, at every instance, you have to have a suspicion in your head regarding what you are dealing with. But after all of this is said and done, you must also understand that there are effects of anesthesia because sometimes if the child is glaucomatous and has to undergo anesthesia, there are multiple anesthesia that the child may have to go through. And there are some studies which have said that it causes some neurocognitive effects of anesthesia on the long-term development of the child. So if you have a child like this, where the corneal diameters are large and you have harp striae, it's almost sine qua non of a glaucoma. So I mean, it is more or less glaucoma. It's very rare that, you know, these days you have forceps delivery and trauma at birth. It's more or less always that of the large corneas and there is a harp striae, you can think that there is a glaucoma. But if you see a disc like this in a child, you know, where you can see an asymmetry, but is this glaucoma? Obviously not, because the disc is large and so therefore the cup is also large. So you have to take the whole picture into account before you actually consider what is glaucoma. However, on this particular case, you can see that obviously there is a glaucomatous optic neuropathy, and therefore this diagnosis can only be made by the clinician. It is glaucoma. What about these discs? These are all discs of myopic children. And you know, if there is a child who has myopia, it is very difficult sometimes to distinguish whether it's glaucomatous or not. In fact, now they're saying that if it is a childhood myopia and the myopia is increasing, there is a possibility that the child might actually have an underlying raised intraocular pressure which is manifesting as a myopic increase in the axial length. Not only does the intraocular pressure rise cause a myopic change in a child, but even the myopic change in a child can cause changes in the fundus. And this is what we have also observed, and there are some reports from South Korea which show that there are changes in the morphology of the disc as the myopia in the child progresses. So for all evaluations of the disc, it's important that you photograph it, and in an OT setting, we have handheld cameras where you can actually take photographs. You can give these photographs to the parents, because this is something that you need to evaluate over a long period of time. So therefore, if the parents can show you that this is what my child's optic disc look like, then 2 or 3 years down the line, you can say, but yes, it is progressing or worsening or whatever, getting better. But if you can't do disc evaluation because of a corneal opacity, then sometimes you may have to use an ultrasound to actually look for cupping in certain cases. This was an interesting case. This child came to us with borderline corneal diameters, a disc which looked almost cupped, which was quite an extensive cupping, but the intraocular pressure was absolutely normal. So when we went into the history, we realized that this child was born premature, and he had signs of leukoencephalopathy. So sometimes you can have a disc which looks like being glaucoma but actually is not, and therefore you need to investigate further to actually see whether the child needs treatment or not. So to summarize, I can only say that if there are harp striae in the presence of large corneal diameters, they could probably be diagnostic. Intraocular pressure, because of the anesthesia, cannot always be relied upon, and especially sometimes the intraocular pressure will be absolutely normal and the axial length is going on increasing. So then you have to look at the disc also very, 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 very well, because there could be an asymmetry or a change in the progressive change in the optic disc, which could lead to a glaucomatous optic neuropathy, which can only be looked at when you do serial photographs of the discs. And of course, as I said, changes in the axial length could also be sometimes the only way by which you can diagnose glaucoma in a child. This was a recent child that came to me with normal looking anterior segment more or less, and very high intraocular pressures in both the eyes. He had high myopia, there was no family history, but the corneal diameters were somewhat small. We did a genetic testing. He was supposed to be diagnosed as juvenile open-angle glaucoma, but because it was a little interesting to me because the corneal diameters were slightly small, I looked for that, and we found a mutation in the COL4A1 gene, which incidentally the father also had it. Now when we examined carefully the child, this mutation is associated with a posterior embryotoxin and cerebral lesions, and when we examined the child carefully, we found that there was a posterior embryotoxin in this child. So the COL4A1 gene is associated with axon field rigor malformation and retinal tortuosity, but there was no retinal tortuosity in him. And these children require repeated MRIs primarily because they have cerebral vascular malformations. And when we did his MRI, we did find that there were some changes in the cerebellum. The mother also gave some history that there was swelling on one side of his face when he was born, but obviously they attributed that to the birth trauma, probably because of the forceps delivery. But it was interesting that because of a genetic diagnosis, we were able to screen the father, and the father turned out to be having high intraocular pressures, and he also had a posterior embryotoxin. So here it is not just the diagnosis of the child that is important, and it is not that it's glaucoma that you're always looking for. It's something much more than that. You see, a genetic diagnosis actually revealed so much in the family that probably we wouldn't have been, I mean, the child was operated and went on, and many years before a genetic diagnosis became evident to us, we were just following this child as a juvenile open-angle glaucoma. So sometimes we are not looking only for glaucoma, we are looking at many other systemic features, and these have to be ascertained, and that can only be done when you're really following up these children well. Thank you. And of course, I need to invite you all for our IPGS meeting, which is happening in the this December in 12th, 13th. Thanks.
Thank you, Vinay, for the excellent talk. We'll have question answer discussion at the end of all 4 presentations. Our second presenter is Dr. Sirisa Senthil. She will be talking on what is the best way to measure IOP in children. Dr. Sirisa, please.
Good morning. So Vinay has actually briefed us about the estimation of intraocular pressure in children and what are the other parameters that we need to look at as well. So I'll just give you an example. This is a child who presented at 3 months of age. Intraocular pressure with Perkins under general anesthesia was 8 millimeters of mercury. Corneal diameter was 12 millimeters, and you can see this corneal edema and multiple HARPS striae. Is this glaucoma, and would you operate? So if a pediatric ophthalmologist is seeing this child, there's no question, even without you telling us what the intraocular pressure is and what the corneal diameter is, we know that there is HARPS striae, there is corneal edema, and it has to be congenital glaucoma, primary congenital glaucoma. But yes, you can have other secondary associated conditions as well presenting with this. So this brings us to, is intraocular pressure important in estimating the children? Do you have other features that can tell you that there is glaucoma or not? Also give you another situation which is not uncommon, and I think in the other parts of the world, this is the most commonest glaucoma that you see post-congenital cataract surgery. A 3-year-old, intraocular pressure of 24 millimeters of mercury, horizontal corneal diameter of 11.5, and disc is absolutely normal, central corneal thickness of 680. A borderline elevation in intraocular pressure, disc is healthy. Is this glaucoma? Should you treat or not? So I would be taking you through the few of the important things that we have learned over a period of time to diagnose glaucoma with regards to intraocular pressure, and how do we use it, and how do we use CCT in the evaluation. So do you need to measure IOP in children? Yes. Whom do you need to measure the pressures? All those at risk and those suspicious of glaucoma, primary congenital glaucoma, post-trauma, previous intraocular surgeries, steroid use and things like that. And which device do you use? I think that we will go through with the presentation. So there's no universally accepted intraocular pressure which is normal for a child, because that is again very variable. Child's eye stretches rapidly in response to elevated intraocular pressure, so there will be changes in the cornea, axial length, anterior segment, refractive error, as well as the optic disc in response to intraocular pressure. Depending upon what those changes are, sometimes the eyeball enlarges to accommodate the intraocular pressure that is elevated, and hence one may not be able to find the IOP that is elevated. Also because let's say you have an enlarged cornea, especially let's say you have an acute hydrops, because of the corneal edema itself and an acute gush of fluid that happens and the fluid that gets into the stroma, one may actually be estimating an IOP which is on the lower side. So one has to definitely look at all the other features before one diagnoses glaucoma. However, intraocular pressure is definitely the parameter that you will monitor and treat. Measurement of IOP in children is again very difficult. They are not cooperative. And because of the glaucoma itself, they can have a lot of discomfort, and they may not be even opening their eyes to check the intraocular pressure. So one can do IOP estimation depending upon the age of the child and the cooperation, either in an awake state or under sedation or under general anesthesia. The issues with general anesthesia, as Vinay just pointed out, that there are several features that can actually affect the way the IOP is estimated. And I'm not saying that you should not do an anesthesia checkup. We need to do an anesthesia checkup, especially if you have to decide on whether to treat or not to treat, or you have to step up your treatment. But what we need to be aware is that just the way of having a laryngoscope go in, or when you're trying to intubate, intraocular pressure goes up, and this IOP can be persistently elevated for a few minutes after the intubation. We also need to know that all the anesthetic agents that we use has some effect on the intraocular pressure. Some increase the IOP, some decrease the IOP. The commonest agent that we use today is sevoflurane and sometimes isoflurane. They do decrease the intraocular pressure. This was a study that we did where we had shown that in the children, before inducing anesthesia, we did the intraocular pressure measurement. Immediately after induction, we did it, and after intubation, as well as at the conclusion of the surgery. And we used two different types of tonometers. Sevoflurane is the most commonly used anesthetic agent. What did we find? We found that the intraocular pressures were down by at least 5 millimeters of mercury. Hence, the upper limit of cutoff, as per the CGRN criteria, is 21 millimeters, cannot be applied here. We need to have it much lower. 16 or lower, 16 possibly would be a lower limit of cutoff. This is again a number. In some patients, it could even be 10, as the case that I had shown earlier. And we also need to understand eye care and overestimates the intraocular pressure compared to Perkins by around 2 millimeters of mercury. Other factors that are there are speculum that you use, so never record the intraocular pressure with a speculum in the eye. You can try and hold the lid, but not press on the globe. Separate the lids very gently and record the intraocular pressure. This again is a challenge if you have small palpebral fissures or if you have microcorneas. In situations like that, we may need to use a tonometer with a tip which is smaller, which is like an eye care tonometer, although you know it slightly overestimates the intraocular pressure. The best way is to relax the child and try to check the intraocular pressure in the clinic, but this may not be possible all the time. Which tonometer do you use? I think any tonometer that we have is fine, but we are used to using a Goldman applanation tonometer in an adult, and similar to that, Perkins is what we use in children under anesthesia, but to do that in a kid who's uncooperative in the clinic is not practical, and if you try to pull the lids apart and try to forcefully record the intraocular pressure, obviously it is going to be higher. So this is our preferred method under anesthesia. Tonopen one can use, but again you need to use anesthesia if you have to use a tonopen. If I have to use a tonometer, other than the Perkins, I would use a rebound tonometer. And rebound tonometer, in fact, I would say after we started using rebound tonometer, the number of examination under anesthesia for these kids have come down significantly. So we only do it only when it is necessary or when you have to have a management decision that has to be taken. And the results are variable for people under anesthesia as well as in the clinic. There was another study that we did, because basically we wanted to find out whether is it appropriate to actually do an eye care and send the baby away saying your pressures are okay or not. So we did it under the anesthesia in children with clear corneas as well as scarred corneas. And what we found was there were two different tonometers used, both the Perkins and the eye care. And with the mean difference between the Perkins as well as the eye care was about 2 millimeters of mercury. But of course, you need to understand that you could have the limits of agreement which could be variable. But what I would like to say is it's within 2 millimeters of mercury difference between the two tonometers. But the most important and the interesting finding that we had was if the intraocular pressure recorded by eye care was 19 or less, it agreed very well with Perkins. And if the intraocular pressure measurement was more than 19 millimeters of mercury, the agreement was not so good and it was highly variable. So what we take home today is that if the IOP recorded by eye care in the clinic is 19 millimeters or less, I wouldn't subject the child to examination under anesthesia. I'm fine with the IOP reading. If it is more than that, then we would like to confirm it by doing an examination under anesthesia. CCT, I will just touch upon it. CCT is important because it varies with disease state and corneal changes in the child over time. But we need to remember that you cannot use a nomogram to kind of correct the intraocular pressure based on the CCT. One example that I gave you in the beginning, like if you have a very thick cornea, borderline intraocular pressure, discs are healthy, no other changes like myopic shift in refraction and things like that, and no increase in axial length, you may be okay with that, like you may want to observe. But you know that CCT is thick or thin, so you may try and understand whether you're overestimating or underestimating the intraocular pressure, but please do not use a nomogram in children. So just to summarize, evaluation of the child, IOP is an important parameter, but you have several other factors that you need to consider before you say this IOP is elevated or high. Try and examine the IOP in a child while the child is cooperative. If not, we may need to sedate or try to do an examination under anesthesia. But remember that anesthesia definitely has an effect over the intraocular pressure, it often underestimates the IOP. Avoid speculum, and intraocular measurements should be done immediately after the stabilization of anesthesia. And consider the fact that whichever tonometer you're using, try and use the same tonometer over a period of time. Thank you.
Good morning. Now I'd like to invite Anil Mantel for the talk on cloudy cornea at birth, always glaucoma or anything else.
Thank you. The title of my presentation is Cloudy Cornea at Birth, Always Glaucoma or Anything Else? To answer the question, is it always glaucoma? The answer is no. It may or may not be associated with glaucoma. It may be anything else. Even if it is anything else, it may be associated with glaucoma. So we should be very thoughtful about this and evaluate the child accordingly for the proper management. Giving an example, neonatal corneal clouding, which may be bilateral, it may be unilateral. Even if it is presenting at birth or present since the birth of the child had happened, the several factors are involved in late presentation to us, like the second picture here. It may be associated with primary congenital glaucoma or may be associated with several other anterior segment developmental anomalies or some syndromic association. So we should be thoughtful. The differential diagnosis is written here. From my 35 years of experience, I'll give some example to really go into the depth of the problem. Birth trauma is an important differential diagnosis. This child was referred to us after 2 hours of birth. History of forceps delivery. The referral letter noted that it may be congenital glaucoma, may require treatment. That's not true actually. Forceps application has given rise to injury to the cornea, given rise to corneal edema mimicking primary congenital glaucoma. We evaluated, treated the patient with mild steroid for a tapering dosage for about 6 weeks, and you can see the picture, how the surrounding cornea cleared and the vertical fold along which the cornea was molded is seen here. It is more common in the left side because of the LOA, left occiput anterior position at delivery. 2 other presentations where it was associated with birth trauma. Now, slit lamp examination and examination under microscope, gonioscopy and intraocular pressure checkup should be done carefully to establish the diagnosis. Here is a presentation, very common differential diagnosis, CAHD. The classic appearance associated with normal intraocular pressure, normal corneal diameter, and if gonioscopy is possible, it can be seen, and the increase in corneal thickness really clinches the diagnosis. It may be associated with congenital glaucoma, that is combination of CAHD with congenital glaucoma, which is a rare entity, but it is possible. Now, even though corneal edema was there at presentation, this picture was taken and the diagnosis was mucopolysaccharidosis. You can see the clinical appearance here. Intraocular pressure was normal. The management was done by internal medicine specialist. A patient presented, I think, within 2 weeks of birth. Both the eyes were having congenital corneal clouding, which is more in the right eye. But if we see carefully, there is prominent Swalb's line and the classic features of Axenfeld Rieger anomaly. You can see the upper picture at pre-op, the lower picture at 6 months after the operation when the cornea cleared, prominent Swalb's line is clearly seen. Even though corneal edema at birth, careful examination will reveal there is no iris. Clinically, iris is absent. It is clinical aniridia associated with congenital glaucoma. You can see here the dentate process. Unilateral congenital glaucoma. You can see right eye corneal diameter is more than left. If we see carefully, the lid and the S-shaped contour of the lid here and the caffeolate spot clinches the diagnosis. It is a neurofibromatosis with congenital glaucoma. Look at the corneal edema. We operated on the child, corneal edema cleared, and evaluation revealed extensive enlargement of the bony orbit, which is very classic of neurofibromatosis. This is the very advanced case. Now, this is the artist diagram, what anterior segment structures are involved in a case of advanced case of anterior segment dysgenesis. You can see, along with corneal edema, there is so much of change in the iris, and here is a situation. Corneal edema, iridocorneal adhesion, and lens was also touching the back of the cornea, Peters anomaly. Ultrasound is of great help in distinguishing several situations and clinches the diagnosis. This child was referred to us at the age of 3 months. Corneal diameter in the left eye was enlarged, corneal edema, and the referral note was the patient may be having congenital glaucoma for management. Actually, when we evaluated the child without anesthesia in the office, we saw in the left eye, white glow in the fundus, and we suspected. The B scan revealed the intraocular mass, and it was diagnosed to be having retinoblastoma, was managed by our ophthalmic plastic surgery chemotherapy unit. Ultrasound biomicroscopy is of great help in most of the situation where it is associated with corneal edema and anterior segment developmental abnormalities in the form of iris cyst. It was managed accordingly. When established primary congenital glaucoma, the treatment is primarily surgical, neonatal onset glaucoma. I'm just giving few examples, 2-3 examples. And preoperative appearance, and you can see 6 months postoperative appearance, surgery improved the situation. Here is the picture. HABSTRA is seen. This child operated at the age of 2 weeks and completed 28 years of follow-up. Again, unilateral congenital glaucoma, operated. You can see the lower panel of pictures shows how dramatically the corneal appearance improved, and the picture was taken 2 weeks after the surgery. The child completed about 10 years of follow-up starting in 6th standard. Here is bilateral involvement more in the left eye. We operated 6 months postoperative appearance, showed dramatic improvement in both eyes, but you can see in the left eye, HABSTRA region is still having residual corneal edema. A child who presented with left eye corneal edema, diagnosed as other eye normal and this eye is involved. Operation was done in the left eye. The last picture shows 10 years postoperative appearance. In a case of this kind of situation, unilateral glaucoma, proper evaluation should be done to rule out the diagnosis that glaucoma is not there, but periodic examination may reveal the development of glaucoma in the other eye in the later period. So we should be very careful. Thoughtful examination, proper management is required, and lifelong follow-up is required for the management of these cases. Thank you.
Thank you, Dr. Mandal. So next will be Sushmita, who will be speaking to us why accurate phenotyping is so important. So those of you who have questions, maybe we will take the questions at the end of this session, or you can either ask us or maybe write it on a slip and then pass it on. So we'll give time for Sushmita.
Good morning. We see a couple of more people, so that's nice. I think this will be another perspective on Dr. Mandal's talk as to why we nowadays understand that phenotyping actually has implications for not just the diagnosis, but also the management that we do. So the problem is that the childhood glaucoma can be very similar on the surface, right? They all come with babies with white eyes, and yet there are myriad hues underneath. So you have no idea what lies beneath these still waters. We've taken informed consent because we've shown pictures of these babies, but then the context is much better when we see them. So the outline would be what we've learned along the way and what we do every year. I think all of us say something different the year after and the year after, and it's been very humbling that what we thought we knew actually turns out to be what we actually didn't. And I'll show some snapshots of phenotypes and one or two pearls on the importance of why I think accurate phenotyping is important. So Dr. Mandal has shown us acute eye drops. The take home is they all do very well if treated in time. So if you have acute eye drops, there's no point saying that my OR next date is 4 months away, because then you would lose the battle. So if you have a person saying, or a mother distraught that this child was perfectly fine 2 days ago and has now become white, so it's important to really intervene fast. And if you can see the picture up there, that's how the Harb's striae actually stretches for all that fluid to get in. But another interesting point was that we noticed when we thought we were dealing with a unilateral glaucoma and we treated the acute eye drops and we weren't doing bilateral simultaneous surgeries, the baby sometimes came back with an acute eye drops of the other eye. So obviously there is something wrong with the desme or the endothelium of these children which predisposes them to acute eye drops of the other eye as well. So we started doing bilateral surgery. This was the only indication of bilateral surgery that we started doing after understanding or observing that. But now with COVID coming in, we do bilateral simultaneous surgery of most children anyway. And after that, we haven't seen acute eye drops in the other eye, because more often than not, you will have some sort of PCG going on in the other eye. It's just that the acute eye drops hasn't manifested as yet. Recently, GAT has been our go-to procedure because it's nice to be able to treat 360 degrees of the angle at the same time. Now, this was a child who, again, classical acute eye drops, and this is, but when we took the kid on the table after a little bit, or by the time the anesthesia and the clearances are done, we always put them on some drops. And then we actually noticed that the cornea seemed to have cleared a bit, even though the look of the angle was very hazy. So this is just a short demonstration of the fact that sometimes you can be foolhardy enough and manage that. So you can see it's very hazy in the center, but we saw that there was one part in the superior nasal portion where we could see the trabecular, the angle. And we said, okay, there's no harm in trying. We can always go in and do a CTT as planned. But then you can see the sutures going in so easily into the Schlemm's canal because it's an acute thing. The Schlemm's is open, and it actually came out from the other side, and we managed the GAT, and this child actually cleared as well as a CTT. So if I can go in and not cut up the conjunctiva and sclera and do a combined trab with trab and get away with a GAT, it's possible. So I thought it's important to say that. So we've been talking about this phenotype. This is classically how the baby presents. Afterwards, of course, they come with completely white corneas, ectropion UVA, severe iris hypoplasia, and they are easily one of the worst glaucomas that I've had to deal with. They all come in the neonatal period. It is not primary congenital glaucoma. We've termed it a neonatal onset congenital ectropion UVA. Dr. Arif Khan used to call it partial aniridia, but he agrees that this is a better term because aniridia sort of connotates PAX6, whereas this isn't. This is a biallelic CYP1B1 cytopathy with very, very intractable glaucoma. In our population, it is R390H. In the Gulf, it is G61E, but whichever is the dominant population in that particular ethnicity, that's how they come with. This baby actually started our rubella journey, and the lessons learned are if you see a white cornea and a small eye and optic disc cupping, think rubella. And the connotation of that is if you think rubella and you test them, you will then think of cardiac anomalies, you will think of hearing defects, and you will think of things that you didn't think of earlier. And we used to miss them. But now, neonatal onset, if we have a smaller eye rather than ophthalmos, that is an important pointer towards looking for rubella, at least when we look for it, when we know. CPA has been a heartbreaking journey for just baby. I've shown this many times, but we recognize it very well. The take-home point is a silvery blue hue on the cornea. Prompt and ultrasound biomicroscopy. If you don't see the lens, please don't enter this eye, because they're usually hypoplastic ciliary processes and they immediately result in an atrophic or a thusical eye. But the also important thing is give them high plus glasses. So this baby is not to be written off. So he has a high plus glass, sometimes not just plus 12. You have to keep on doing a subjective. He's around with a plus 14. I've given them up to plus 17 as well until they can see. And he sees his cartoons and is mobile with his glasses. So the important thing is high plus bifocal lenses. Let's not forget that. Aniridia is a conundrum. Aniridia, it's one of the most intractable glaucomas, especially when they present in childhood. And when you have a family of aniridias, you have a whole family to take care of. This is classical. The corneas are not very large. You usually don't have ophthalmos, and you have very thick corneas. So the IOP recording is something to be thought of. And of course, if they have nystagmus, they have a foveal aplasia like this. But having said that, is aniridia a phenotype or is aniridia a disease? So this preterm baby comes. This is in the OR. You can see there's absence of iris. You can see the edge of the lens, and we just said, oh, aniridia, and that's what the UBM was like, stumps of iris, and fine. When we did the genetics, it was actually FOXC1, and this is a FOXC1 deletion. And when you have a FOXC1 deletion, the iris doesn't form. And we kicked ourselves because when we looked harder, we could then see the telecanthus, we could see the periumbilical skin, and we didn't ask the mother the history, but he also had a ventral hernia which was operated on. So sometimes you miss these things in a busy clinic, but that's no excuse for not phenotyping them better. We should have thought of all that. So if you have absence of iris and there is no nystagmus, and the child seems to be seeing well, think again, because it's a very rare aniridia where aniridia as a diagnosis where you would not have foveal hypoplasia and a nystagmus. So this is again absence of iris, spot diagnosis, aniridia with congenital glaucoma, intense epiphora, photophobia. Of course, he needed a combined trap with trap, and this turns out to be something which we had noticed. Neonatal onset CU with severe iris hypoplasia. Sometimes iris hypoplasia can be so bad that you call it aniridia. Again, a large cornea and no nystagmus, no foveal hypoplasia. That's not aniridia diagnosis. It's a phenotype, yes, but I think we should be relooking these, and I think we as a group would be party to relooking phenotypes rather than just saying absence of iris is that. So this is a CYP1B1 cytopathy, and it's important to recognize these. So to summarize, I think clinical examination is the hallmark of management of all childhood glaucomas, just as all glaucomas. And ensuring good vision is our goal, not IOP therapy, but we need to look out for the family because many of these glaucomas might be inherited, and we need to hold these children's hands lifelong. Thank you. I, of course, invite you to the IPGS, and I thank all my senior residents over the years who really have a tough time, but they come out, I think, richer by the experience. Thank you.
Thank you, Sushmita. So we are open for questions. Any questions? Yeah, there's a mic at the back, Sushma.
So, yeah, I just wanted to ask about the aniridia part. Now, when we have aniridia, which says CYP1B1, where we don't have a classical aniridia, so would our management change in terms of visual rehabilitation, in terms of glaucoma management?
Prognostically, it would change. That's one.
Yes.
You wouldn't be bothered so much about the family. Systemically, it would change. You wouldn't be looking for Wilms tumor. You wouldn't be looking for genetics will help. And the prognosis in the sense of you can have 50% of aniridias without glaucoma. So just having an aniridia does not essentially mean that it is glaucoma. But if it's biallelic CYP1B1, I would tell them that the fovea is fine, everything is fine. If you have a good pediatric cornea specialist with you and you're lucky, then if the keratoplasties are done, they would do better. So in that sense, these are two different diseases. A biallelic CYP1B1 is a very different disease from PAX6 aniridia. And if
Yeah,
you know
and
that.
I think also in terms of inheritance, so
Yeah.
would that
Yeah, so
is
that's
another thing
homozygous
that
recessive.
adds.
You would have parents who are carriers, whereas a PAX6 would be autosomal dominant. So one parent would be a carrier, but the chance of the rest of the families would be 50% for each child, where aniridia is concerned. The same thing for Mendelian genetics, yes.
As any autosomal dominant.
Yeah.
Yeah, thank you.
It's a difficult situation compared to primary congenital glaucoma aniridia. Even if you are controlling pressure with a surgical approach, long-term follow-up may reveal intraocular pressure is still rising, second surgery is required. Sometimes corneal edema is not clearing totally and scar is there. You may have to go for penetrating keratoplasty. And that again brings back the high pressure. Pressure again rises. So sometimes multiple surgery. We have several children where multiple surgeries were done. Children are doing reasonably well, but overall prognosis is poorer compared to primary congenital glaucoma.
And just to add, Sushma, the added problems of a limbal stem cell deficiency aren't there. So there will be no keratopathy. I would be far more inclined to get a keratoplasty done for CYP1B1 rather than an aniridia because they really do well. So the keratopathy part is lesser. So as I said, they're two completely different diseases, but if we treat them all as the same, it's possibly not.
I have one question.
We have done combined trabeculotomy, but having said that, in some cases, embryological abnormality may reveal that Slem's canal is, you cannot find it out. In that case, you may have to convert it to trabeculectomy. And the iris stump should be removed carefully, otherwise it will block the ostium again.
My question is, how important would you consider the gonioscopic finding in a primary congenital glaucoma suspect? I ask this question because there was one case in which one eye was very obviously having primary congenital glaucoma with classic Habs triad, corneal edema and raised intraocular pressure, but the other eye seemed relatively corneal, cornea was clear, but on EUA the IOP was around 20-22 with tonopen, and corneal diameter was also increased around 13.5. But disc was normal, cup disc ratio of around 0.2, and the gonioscopy on the other eye was normal. It did not suggest any goniodysgenesis. So can we observe these children without operating?
No, if you have an enlarged corneal diameter and under anesthesia IOP is 20, and you have a contralateral eye with glaucoma, that is glaucoma. So often we need to remember that primary congenital glaucoma is a bilateral disease. Very, very less chances that they are unilateral. If they are unilateral, always look for a secondary cause. So I'm not saying that PCG doesn't present as unilateral. We know that by literature it's about 10 to 20% of the people present unilaterally, but Vinay's group has also shown that if your corneal diameter is beyond 12 millimeters, even with pressures being normal, disc is healthy, over a period of time developing glaucoma in that eye, the tendency for, if you're looking at risk factors, the risk factor for developing glaucoma in the contralateral eye in future is very, very high. So this example that you gave is glaucoma that needs to be treated simultaneously.
Thank you. One more question is regarding Axenfeld-Rieger syndrome. So sometimes we have cases which have very poor endothelial cell count. So how best to manage these cases? Because there's a family where the father was one-eyed and he had cataract, he had poor endothelial cell count, and his IOPs were very high, above 30 with maximum medication. And there was ciliary, not ciliary, I think intercalary staphyloma. So the option, he had cataract. So how best to approach this case? Because phaco-trab was not an option for this gentleman, he had staphyloma. So I didn't want to consider phaco-trab. So is cataract surgery with ECP a good option for him.
What's the age of the patient?
He should be around between 40 to 50.
Yeah, recently actually we've seen that a lot of these Eigenfield riggers have very poor endothelial counts, and as time goes by, it gets only poorer. You know, so I mean, as a glaucoma specialist, I generally refer them to a cornea specialist to take care of the cataract, as well as simultaneously at another sitting or before that do a DSEC. So I mean, I do not take them up for a cataract surgery primarily because their cornea decompensates, and any intraocular surgery just decompensates their cornea. They need to be referred to a cornea specialist for a corneal transplantation. And very interestingly, I want to share this, is that the PITX2 mutations are generally more associated with the corneal decompensation for some reason compared to the FOXY1. So this is a paper that we are going to publish very soon, where we have seen over a period of time that the PITX2 patients tend to have a corneal decompensation very quickly, and the necessity of corneal transplants is much more in those patients. So please don't take it up in your hands, just refer them to the cornea specialist.
But the IOPs are also high. So
Yeah,
with
I mean,
yeah.
you know, the question is that you have to treat the intraocular pressure with a DLCP or something like that. Maybe
Yeah,
do a just
that
partial.
is what I wanted to
absolutely,
actually.
for the time that the cornea can be taken care of. Once the cornea is taken care of and the intraocular pressures are controlled with maybe Diamox or DLCP or anything, you can take up for a permanent glaucoma surgery at a later date.
Thank you.
So maybe I would differ a little bit. I would say control the pressures. You can do a tube in these eyes because that is possible. They are very, very difficult. And if you have to ask which type of tube I would choose, it will be a non-valved implant because they have a very, very high tendency for fibrosis. Trabs don't do very well. Some of them are okay, but majority of them, and a valved implant does not do well in the long run. So I would do a non-valved implant, bring down the intraocular pressure, and if there is cataract that is significant, then you may want, usually this is our experience with our cornea colleagues, they say you finish your cataract because often the cataracts are not very hard. You can remove the meaning like you can do a lens aspiration, place the intraocular lens, settle it down along with your tube surgery, then send them for a DSEC because once the pressures are under control, and they would prefer to do a procedure in a quiet eye, and they don't like to combine it with a cataract surgery. So I think each place has a different way of managing things based on their colleagues, but good thing is speak to your cornea colleague and understand that both of you together have to manage it in a safe way.
So our cornea colleagues would be very wary of doing a DSEC in the presence of a tube. They hate doing that. So if they have a tube, they'd say, we don't want to do a DSEC. I
Is
would much
DLCP
rather
an
do a
option
PK.
in these
ECP
cases?
would be an option, I think.
Yeah,
That
that's what I
ECP
thought.
would be the first and the least whatever thing that I would think of. But yeah,
Thank you everyone for those great talks. Pardon my ignorance, I don't have much knowledge in pediatric congenital glaucoma, but I am a pediatric ophthalmologist. I have one question in the genetics of CYP1B1 that Dr. Kaushik was presenting on. So you mentioned about the CYP1B1 keratopathy that is seen, but not all CYP1B1 patients have these keratopathy changes.
No.
So are there any genotypic differences that you have noticed
Yes.
in this patients that specific genotype cause keratopathy, and do we have to counsel them way beyond that?
So we've seen the arginine 390H is the worst, and the arginine 368H is the best. And I've asked every geneticist, including Ria, how come just from 390 to 368, the same missense mutation between arginine and histidine? Those are very good ones. I'm very happy with the arginine 368H, which is the good garden variety infantile PCG where the GAT works and you have to do nothing else, is that. And the R390H, spindle-shaped corneal opacity, a little bit of ptosis, inferior pannus, and horrible glaucomas. And there are sometimes when on the gonioscopy, I'm tempted because now that GAT is in, I said, kar de, and then my resident pokes me in the back and says, ma'am, R390H, I don't even try it. There's going to be no outflow in them. So they're very bad. So in that sense, yes, we've learned. But the other thing is the missense mutations, the other ones are all right. And interestingly, I don't know, you as a geneticist should tell us, I haven't seen any deletions or anything in CYP1B1. They all seem to be either missense or something. So, but I've seen a lot of deletions and duplications in FOXC1 as well as PITX2. I mean, these are just observations from a clinician. Someday I would possibly understand that. But what I've seen is in our population, and remember arginine 390H, surprisingly, is a founder mutation in Pakistan. And from the papers I've read, I haven't seen this variant in LV Prasad. Shubho's variants of CYP1B1 are G61E, which is more Gulf-like. So ethnicity does matter. Vinay's papers don't show R398 so much, but they show mixtures of both. So possibly the ethnicity of RPC is a very mixed ethnicity. Ours is very Jat Punjabi. Jat Sikh is the ethnic population which has R398. We see all of that. Pakistan sees that. Sarfarazi sees that. So ethnicity matters. So I don't think we can take it away and say that every population would have that. And this is not seen in the West at all. Biallelic, they don't see. So it's very interesting as to where it comes from.
If I can add a couple of points to this, we also see R390C and also R390H is also something that we see. 368H is also something that we see. But if you remember, when whatever compiled data that we have as to the CYP1B1 keratopathy, the eyes with CYP1B1 keratopathy, apart from the 390C and H, we also see C280. In fact, of all the mutation variants that we have seen, R280 is the worst. They are so difficult to manage. Even 390C, some of them do well. So it's not like every single one of them have a very bad prognosis. One eye can have a bad disease, and other eye can have an intermediate or a simple disease where you can treat with one surgery, they are okay. But there are some phenotypes which typically have a cytopathy and they just don't respond to whatever you do. Requires a keratoplasty, but if with a keratoplasty, again, the long-term prognosis is not so good. The tendency for them to develop an infection is very high. Steroid responsiveness is extremely high in these eyes. So of late, what we've been doing is that we do a sector iridectomy in these patients, and typically these patients also have a dilated pupil, that is ectropia nevus, so much so that mid-periphery and the periphery, they can see relatively okay. So if the scar is not too big, if they're in the mid-periphery, or even if they're in the center, pupil is very well dilated, I would let them be that way rather than ask for a keratoplasty in these eyes. So yes, we know very little. I think the access to genetic testing is available only for the past few years for us. Maybe with time, we will be able to understand it better, and we will have, maybe tomorrow when you do a testing and say, okay, this is the genotype that you have, in the long term, this is how it's going to behave. So the long-term outcomes and prognosis, definitely genetics has a role to play, but I think we need to understand much more. And what we tell today, we may change 2 years from now.
And the other interesting thing is that sometimes with these, we've seen VUSs in other genes implicated for PCG. And there are some papers which say possible digenic inheritance, but there is no functional data to substantiate that as yet. I'm sure there would be some way to so for instance, we have CYP1B1 and TEC. Now the TEC is a VUS, CYP1B1 is pathogenic. And you say that, no, the phenotype is like CYP1B1. But apparently you don't really know, because TEC is also implicated in PCG, and whether it has exacerbated the effect of CYP1B1 on the trabecular meshwork, I'm not sure. I really don't know. So our geneticist says don't discard your VUS, because VUS today might be pathogenic 3 years later or something. So just hold on to your VUSs, especially if they're two. So I don't know, there's so much we have to learn from you and Ria and everybody else, but these are
just
early.
One more thing to add was is CYP1B1, because it says it's just expressed in the trabecular meshwork, but with the keratopathy findings, do you think it could be a neurocrystopathy where neural crest cells could be affected?
I'm sure.
Yeah.
But why is CYP1B1 affecting one keratopathy and not the other cornea, and why it is completely the same variant, completely normal child in one and a horrible cytopathy in the other? So those are unexplained things. I don't know.
So should we move on to
Thank
the
you.
next
To the panel.
panel? Yeah. So Sushmita will take over.
Yeah. So actually, the first talks were, I thought, just a kickstart as to what we need to talk about. You can keep sitting here. All right. Okay.
Let the panelists come here, it will be
Right.
nice.
Right. Okay. So I'll call upon Sunita, Sushma, Ria, Gaura, and of course all the faculty. We would like your inputs as well. So can I have the panel? Yeah. Can we have the next slide, please? Or maybe I'll do it from there. No, no. Right. So, yeah? No, it's fine. Sure. No problem. Okay, so Sirisha had come up with the idea that let's talk of ancillary testing, because we all talk of corneal diameters and IOP and disc and gonioscopy and everything, but let's go beyond that. So I'll put it to Sushma. When would you use B-scan, UBM and ASOCT to kickstart?
Okay, so B-scan, in any patient where we can't see the fundus before surgery, B-scan is a must. We need to rule out tumors, hemangiomas, and other things whenever we are looking at glaucomas, because we have to rule out secondary to call it as a PCG. Well, UBM and OCT, typically in a situation where we cannot see the anterior segment, or it's not like a normal pupil, and we want to look at what are the adhesions, what is the angle like, where you can't do a gonioscopy and you can't look at the anterior segment morphology to make a diagnosis.
So every child with a white cornea, ultrasound of course, every
Undergoes.
child with a white cornea UBM?
Yeah, every
in the
child
OR?
where you can't see the anterior segment structures, the opacity is of that grade, then it has to undergo a UBM or
UBM as
ASOCT to
well. Sunita,
understand.
agreed?
Yeah, so actually bees can be used for measuring eggshell length also.
Yeah.
Especially in OPD, because you cannot do eggshell length with another measure. And also post-operatively, bee scan is very, very useful.
Okay.
So
Post-op?
because post-operatively, if the AC is shallow,
Okay, first
or if
choroidal,
there is
then fair
suprachoroidal
enough.
or choroidal, and UBM of course differentiate between primary congenital and secondary developmental anomalies, Peters and all.
So suppose the question is we don't have UBM in the OR. Can we still go in, or should we say this is mandatory? Vinay, what would be your take? UBM mandatory, or we can go ahead without a UBM and manage glaucomas, I mean? वो दूसरा माइक भी आगे ला दीजिए प्लीज सेंटर में if you can get
I
the
think
yeah.
the ultrasound biomicroscope in many places is not available.
Yes.
And sometimes it becomes very difficult to actually make a diagnosis without a UBM. You know, for example, I have had patients where the cornea was very hazy and the iris details couldn't be picked up, and then when we did a UBM, it happened to be an iris cyst or something like that. So without the UBM also you cannot do.
Yeah.
But then the question is, if you do not have a UBM, then what do you do?
Yeah,
I mean, then of course you have to use the B scan
Yeah.
with a lot of fluid there, and then use it as a UBM sometimes.
Yeah,
So that
I
is the
agree.
only
So at
surrogate.
least some sort of
Yeah.
anterior segment, so everybody would have a B scan. And we used to use fluid in the finger of a glove and put it there as a water bath. Having said that, Ken Nischel advocates the use of the linear ultrasound that the anesthetists use, and I've actually seen it. It's quite interesting because you get a picture of the anterior segment as well as the posterior segment in one shot, and if it's all the same, then he doesn't bother with the UVM. It's only if it's distorted that he would go again. So I thought that was a very good time-saving thing. Somehow, I don't know why we don't use it. We should try to use those linear ultrasounds because our anesthetists do use them, especially for neonates when they can't see the vein. So that's just one thought that we could do that. ASOCT. What would-
One
yeah,
more thing
sure.
I would want to add. Again, in the OT, all of us would have access to the endolight.
Okay.
So just the endolight, if you put through limbus, you can actually make out whether the anterior segment is all right. If you're not able to see or you don't have access to UBM, that works very well.
So the endolite is on the limbus, and
Endolite is on the limbus.
and we are seeing it through the microscope.
Yes.
Okay,
Yes. So you
without-
switch off the room lights.
Switch off the room lights, switch off
See-through
microscope lights.
No, no, no. Microscope light can be on, or you can switch off that also.
Yeah.
But you just use the lateral illumination at the limbus with endolite in all directions. Most of the time, you will be able to make out how the anterior segment is.
Okay, that's interesting. So that's something which, so that's a good point to take home, that you can use the endolite on the limbus, use it as a trans illuminator like they use for melanoma.
For the endolite, I think I have seen Dr. Javed showing us when he does this
Okay.
endoscopic DCRs. So he's just right next to my OR. So he showed me that he just puts visco onto the cornea and he puts this endolite onto at the limbus or even at the center, and you're actually able to visualize the 360-degree angles. I was like, wow, this was really amazing. And they in fact recorded onto their endo DCR this thing, so you get a video recording and you can take a snapshots of 360-degree angle. It's really amazing to see that.
So
Actually, we also use that endolite to use it for accurate tube placement. You know, sometimes when the cornea is very hazy and you cannot know where to put the tube, and you don't know where the tube is going, so you can use that endolite for that purpose also.
Yeah, same thing for even doing a capsular excision in a hazy cornea, or if you have to do vitrectomy, you can visualize endolite or with endolite whether there's any vitreous strand in the AC in a situation of a cataract complication. So endolite is quite a useful instrument, I would say.
Yeah. And the question is ultrasound in the OT versus a VR setup with an endolite. which place would have that if every place has an endolite? Usually it's a sterile thing, isn't it? Or
Yes, it is a sterile thing.
so the sister would allow you to open it, and
Yes, yes.
our
So-
sister wouldn't. To put it
So you
anyway.
have to have
Yeah.
good this thing with retina OT so
Yeah,
that you can
retina
get the
OT to
endolite
take
on
it.
demand.
Fair enough, yeah. ASO City, next question. Sirisha, would you use ASO? Oh, you're making a comment about UBM? एक और mic दे दीजिए, please. Okay, there it is. Yeah.
So, I mean, endolite VR surgery, not necessarily. We call it as light pipe. So we have a light pipe, which is a separate one, which has got nothing to do with the VR surgery. It just has a box with an illumination, and then this is connected. It is a sterile instrument. You can
Connected
use-
to?
connected to that light source.
Okay.
So it's a tiny one that we can use, and it's
Even we
available.
have
We
that.
call it as light pipe.
Okay.
Also, what we can do is use the regular torch. You have a pen torch, switch off the room light, switch off the microscope light, see through the microscope, but use an oblique illumination. If you do that, in fact, even in every PCGI, when you see that, you'll see the details of whether there's ectropia uvea, pupil is dilated,
Yes.
small, aniridia, all of that can be seen, unless it is a grade 5 corneal haze where there's absolutely light not going in. Otherwise, even until grade 4, you will still be able to manage to see.
So
So
we-
one cannot say that you don't have a UBM, so we cannot see it. If you have it, it's great. But otherwise, we should be able to visualize it before we go in.
Yeah, we use the torch a lot to delineate ciliary processes. We use that to do the DLCP, so yeah, I'm sure. Okay, ASO City, I'll give it to you. How would you use ASO City in childhood glaucoma?
Yeah, so in totally hazy corneas, it's not possible to use. But if the cornea is not so hazy, we do use it. So in children who are cooperative, older children, it's definitely useful. So where you would like to use it, like let's say you want to know the corneal thickness, you want to use it in a child with shed, you want to differentiate what's happening. I don't use so much for the angle delineation because I've seen both your team as Vinay's team does it to understand whether there's dysgenetic angle or there is a anterior insertion and things like that. But we don't use that routinely for that purpose. But for me to mostly understand if you have a hazy cornea but not so hazy, let's say acute hydrops, you want to differentiate mucopolysaccharidosis with CHED, with congenital glaucoma and things like that. So the cornea is hazy, corneal thickness, what's happening with the decimates, that's more important for me.
So the flying baby has helped us. We'll just go, we just hold it. We've taken it from the retina colleagues. Believe me, you can, if you see trabecular meshwork, it's not glaucoma usually. I mean, if you can't see it, then it's not normal. We can say that. Thankfully, it will soon be published in JAMA, so they sort of found it very exciting. But
Maybe
if you have the swept source cassia, that's what you need, which will take 3 seconds to take the image, or the anterior, which again takes about 5 seconds. but not the regular ASOCT which you use for lens vault or something, but
Maybe
swept source.
post-operatively after GAT, I think you can see whether the cleft
Okay.
is patent. Post-operatively, if the child is
Yeah, sure. I
you
mean,
know,
post-operatively,
cooperative
it
enough.
would be an academic interest for me
Yeah,
personally,
academic.
because with that crowds, I wouldn't, I mean, it was just if I wanted to ask. But
Yeah.
management decisions,
Yeah.
I use it pre-operatively a lot,
Yes.
and it's helped me quite a bit. So I think we'll move on, because we have two for which we have Gaura and Ria here. Ria, if you could take the first one, when and whom to order genetic test, and if so, which test? And then we'll have Gaura take us through how they've helped improve our care, and then we'll have other comments. So these two, when to order and which test to order.
Yeah, when to order, in all cases of congenital glaucoma, it can be ordered as early as birth. Like we have been discussing, because the genotype-phenotype correlation is getting stronger. So we know that CYP1B1 gets managed sometimes by multiple surgeries. Your L3, BP2s will show up with lens subluxations. And the other thing is that in case you're suspecting a syndrome, so there's two ways. If you test at birth and it shows up as a syndromic diagnosis, like a Axenfeld-Rieger syndrome, with the oligodontia and dental care, it can be done before the symptoms show up, versus if you have a child who's a little older and has started showing symptoms of syndromes, then to detect the syndrome also genetic testing can be done. The other cases are where there is family history of glaucoma, for example. So in your POAG and JOAG, we have noted that even with family history of adult onset glaucoma, there are genes that overlap and show up in a 3-generation family pedigree, segregating in that manner also. And the other indication is that which kind of so these are the 3 cases where we order genetic tests more often. And which genetic
No,
test?
Ria, that means all congenital, because that's what we'll be dealing with. Every child with congenital glaucoma should be subjected, do you think?
Ideally, yes.
Ideally, yes.
Yes.
Okay, amongst this cohort of all the congenital glaucomas, would you pick some cherry pick that you have to do it? And ideally you should do it, or you may or may not do it. So have to do congenital
PCGs.
glaucomas? PCGs.
PCGs, yes.
Okay.
Yes. Because like I was saying, so we've done some cohort analysis of the patients that we have,
Okay.
and we've seen that CYP1B1s were needing multiple surgeries. They're the worst
Yes,
kinds,
yes.
and versus tech relatively
Yeah, is
all
better,
right, not so bad. So the management also can be altered according to what shows up in the tests.
Okay.
Yeah. And in terms of which tests, if it's isolated glaucoma, they are mostly correlated with point mutations. So like a whole exome sequencing by next generation sequencing should be good enough. We do not have enough labs right now who are making customized gene panels for glaucoma. The advantage of customized panels, if they exist, is that the labs claim that the library preparation stage, they only handpick a few genes and test. So there are about 15 genes if you give them a list. And so the coverage of those genes in a customized panel will be more. Having said that, there are labs within what is happening in India is that they'll promise you a customized panel, but essentially they are still doing a WES, in which case the coverage is not really increasing. But this is not a blanket rule. If there is a syndrome, like we recently had a Peters plus child and he had syndromic features also. A contiguous gene deletion could also be, a chromosomal deletion could also be present, which is now NGS is good enough to pick it up. But then if you want to know the precise breakpoints and the size, maybe a chromosomal microarray will be a better technique to do that. And also another thing I want to point out with these big chromosomal deletions is that do not forget, even if this is a isolated case, that the parents could be carriers of balanced translocations. So even if it's an isolated case, there could be recurrence risk attached to this. And then there is the discussion to test the parents. If the deletion is too big, it can be picked up in a normal karyotype analysis of the parents, and you'll be able to see the breakpoints.
So would a big deletion in a parent be asymptomatic?
Yes, because it's balanced. There's no particular genetic area that's missing or extra. So they will be asymptomatic completely.
But the same thing would be symptomatic in the baby.
Because it gets disbalanced when the chromosomal segregation happens during gametogenesis and embryogenesis. But then there's that other challenge of the size of the deletion. So karyotype can only detect over a couple of megabases of change. If it's smaller than that, a few kilobases maybe doesn't get picked up in a karyotype, in which case now some advanced techniques like optical genetic chromosomal analysis have come around, which are able to, so picking the genetic test also is quite variable depending on what you're dealing with, and one has to be, whole genome sequencing is not being used as commonly. One only resorts to whole genome sequencing if they do not find their answer in a whole exome, for example. Having said that, we have to keep in mind that the yield of a Exenfeld or a Peters anomaly is anyway low. Only in about 60% cases or less do we actually find a mutation. So whether we should be chasing these high-cost tests is another question.
That's also true.
Then the other indication where testing becomes important is in the prenatal context. So if a family has had one child, de novo instance of primary congenital glaucoma, and they want to know whether it can recur in the next generation, in that case genetic testing becomes important. But there are ethical considerations to keep into mind, because there's visual morbidity but the lifespan and intellect is not particularly affected. So that discussion needs to be had with the parents, and then decisions can be made accordingly.
Okay. And the labs in India also provide something called a clinical exome, which means only the exomes implicated in disease. So
Yes.
they say it's a difference with 6,500 versus 22,000 genes for clinical and that. So short of doing a panel with just 20 genes where you are liable to miss other things which you're not thinking of. And I can confess that I've missed Rubinson Tybee because I wasn't looking for it. I didn't know that it could come with congenital glaucoma, you know. So it wouldn't come if you just do a gene panel. But what is a clinical exome vis-a-vis a whole exome, because they have a difference in cost as well?
Yeah, so clinical exome, so the costs surprisingly are getting very close now. So
yes, they're getting
there's
closer,
barely
but still about 2,000 rupees
2,000,
off. Yeah,
correct.
yeah.
But yes, I do stick by a whole exome
whole
because
exome.
of this very reason.
So
that,
do you think they would still be doing a whole exome panel and then just giving us the report of a clinical exome? Or
I believe the clinical exome and whole exome panels are different. Like the library
is different.
Is
So you
different.
think a clinical exome would have a better coverage, like you said, for the panel?
It's because in certain kinds of congenital glaucomas, the yield is anyway low.
Yes.
I would
That's
rather
true.
do a whole exome over a clinical
Fair enough.
exome.
But
Just
if you had PCG, we could do clinical exome?
could do. One has to be very confident about
About the phenotype, isn't it?
it not turning out to be a shed then.
Yeah, I know.
Only then.
Yes,
Yeah.
yes, true. Okay. Gaura, to you.
Yes. So before we go ahead, I think just 2 points which I wanted to add was when you're chasing something that if you get a clinical exome and it's negative, then you got a whole exome, it's negative. So always go back to the phenotype. Like, do you have the phenotype right? Because sometimes what happens is, there have been cases where it's written as congenital glaucoma. We have been chasing for the genes for all of those, and then when an ultrasound biomicroscopy show that there is posterior ulcer of von Hippel, and then we give the phenotype to the Peters anomaly, and then we get the result. So it's very important that what phenotype you provide to the lab, because like Ria mentioned, everything is done on an exome background, but they are going to look at only those genes that you have given the phenotype for. They are not going to look anything beyond that one. So it's very, very important that you give what phenotype, and sometimes you just modify the phenotype and give it to the lab, you can get the results sometimes. So it's very important. And once you have a very strong phenotype, there could be possibilities that it could just be a single nucleotide change, or it could also be a gene deletions. In that case, if there is a multisystem involvement, or you're actually suspecting a larger deletion, a chromosomal microarray is also one of the testing that you can allude to when you have a very strong phenotype and your other testing have come negative.
And I can confess that I've been stupid retrospectively. oh yeah, this is there, I didn't see,
Yes,
because
it happens
we
to
are
all
also
of us.
blinkered to the
Yeah.
white cornea, high pressure, disc cupping, surgery, GA, and then you don't look beyond that, that's okay. But how does it affect the families? I mean, we get the molecular diagnosis, we get it. Now, next, what do we
Yes,
do?
so when we have a genetic results, the first important thing before we do a genetic testing is to counsel the parents on what are we doing, what are we getting into, and at every point make sure that they understand what are we doing, like what is the implication of this result, how is it going to implicate not just to the child but to their whole family at
Okay,
large.
give us an example. Garden variety PCG, first child, family, what would you tell them? The question that we have is that loop between Shroff is lucky, LVP is lucky maybe, but most of us don't have the the thing made up as to genetic counselor, geneticist, clinician, and then back and family. So for me as a clinician, if I have to counsel, which is not a great thing to do, but if I can take out 15, 20 minutes of time and get everybody out and just talk to them, what should I tell a young couple, first baby, garden variety PCG, I know my GAT will do well. What should I talk to them?
Yes, so it's important that you have the phenotype right, which we usually get it from our clinician, and we establish the diagnosis to the parents that this diagnosis has a genetic implication, that there could be a genetic cause for this one. That's very important for them to understand that genetics is not the only cause for that condition. There could be other possibilities, and once they understand that, then you tell them that why are we doing this genetic testing, or like is it just associated only with the eye, or if there are any other systemic associations that we might come across while getting the genetic testing. And you also tell what are the implications that the child has over the course of time, like how is the prognosis based on the genetic report. Like you can say that there are multiple genes that are associated with this condition, and based on your genotype, the prognosis of the condition is going to be different. Some behave better, some behave worse. In that case, you would need a regular follow-up with your glaucoma specialist. The other thing we always talk about is the risk to the future offsprings if they wish to have. And in that case, we always explain what are the different modes of inheritance that are present specifically for glaucoma genes based on the diagnosis. And then once the parents understand that, okay, these are all the risks, these are the possibilities. Other than this, there are some incidental findings that the lab report gives. So we have to make sure that the parents are aware of those reports, like not just the glaucoma genes, there could be other genes that could be reported.
So do we need to take consent to report those genes? Do we need to ask the parents, would you like to know variants which are not associated but we found? Or do we need to have that conversation?
So I think the report includes three things. One is your primary findings and the secondary findings, and then the other incidental findings. So the genetics board has a consensus that there are list of genes that are mandatory, it has to be released
Actionable.
to they are actionable genes, like your cardiac genes, like arrhythmia genes or a cancer genes. So any of those genes where you can take an action and prevent a life-threatening condition for a patient, those are to be reported onto the file. And the secondary findings the patients may wish or may not wish to have. These are the other risk conditions. But the actionable items, which is by the genetics board, have to be reported. If they wish to have it, it will be reported onto them. Later on, they can come, yes, I wish to know, but it will be there on the lab. We can always request them to give.
So
the
it would be
parents
fair
can
to
consent.
say that the actionable report genes have to be on the report as well? Or
Yes.
can that be withheld to the lab? No, it has to be on the report.
It has to be on the report.
On the report, and the
Yes.
parents have to be told that there is the
It has-
list,
yeah, they have
which
to be
we
told,
will,
yes.
will tell you. But do they have to be told that in case we find something not in this list, do you wish to know, or is it okay if it's not reported?
So
Is
those are
that
your
consent
secondary
required?
findings where they wish to know, then they can give those. Otherwise, they are
Why
not
I'm
reported.
asking this is sometimes on the report there are things like thalassemia.
Hemophilia, yes.
Right.
These are the most common things.
And our geneticists would say that they are so rampant, people are walking around, you could have one. But if a parent goes and does a Google search for those, it's very scary.
Yeah, so it's important that we understand that if the child is actually affected or is the child is just carrier for that disease.
Okay.
So the genetic report mentions that if it is homozygous or heterozygous, and if that condition is associated with a dominant or a recessive inheritance, we should make them understand that your child is just carrying that gene or a variant, and the risk of its a future offspring depends upon the partner's genetics. So not necessarily.
So it's an
that-
implication for the future for the baby. That's also
if they are
important. yeah.
carriers, but if they are themselves affected, then I think we need to evaluate them based on what system is getting affected through a proper specialty referral.
Okay. Any questions, any comments from the, yeah, Rashmi? We have just 5 minutes to end. The last is AI, but we can stick with this.
I just want
Yeah.
to know when should we do the genetic testing for the family members, like other siblings? Should they really have a phenotype, or based on the report that we have, or at the first go itself we have to do for the family members also?
It's a very good question, Dr. Rashmi, because usually genetics, we do not do genetic testing for asymptomatic individuals. But there are conditions which are actionable, like in glaucoma, where we do an exception, where even if the child is asymptomatic, even the pressures are fine, one sibling is having glaucoma, the other sibling is absolutely fine, no other signs, but we can still go ahead and do a genetic testing, because if that child tests positive, then we need to do a early screening, we need to start for those patients. So retinoblastoma and glaucoma are the two conditions in the eye that are specifically considered where you can do a genetic testing in an asymptomatic individuals. Otherwise, it's not considered ethical for us to do a genetic testing in any of the children less than 18 years of age. The
Okay, reversely, sorry, I'm interrupting because it's an extension of that. JOAG parent has children and says test them.
You can do it. We have done it for
Because
many.
the children, myocillin in PCG is not going to happen. But if we find myocillin, would you say that it increases our evaluation of that baby
Yes,
and the
that
risk
is very,
assessment
very
is, yeah.
important for the child.
Fair enough.
I last week only I was counseling a patient with myocillin. The mother is having myocillin gene. One of the first daughter is having, she's tested positive for myocillin. She's just 7 years old. They just go for regular pressure check, and they are getting the regular OCT RNFL
So
thickness.
the surveillance increases
Yes,
and you will
surveillance
catch it. Yeah,
increases.
you
We
can't
can
prevent
catch
it,
early,
but you will
yes.
catch it.
I have one question, just for the clinicians also. Whether genetic tests should be advised before planning for surgery, because as we were discussing the last session, that the prognosis for different surgeries may be different. Because what we are doing is that at the time of surgery only we are taking the sample and then testing it. So what is the protocol for you all, like whether you are doing it with EUA and getting the results?
Yeah, we
and-
don't wait for the results to do surgery. We do surgery
But suppose if
ASAP.
you are planning GAT and it may not be effective in certain subset of patients, and
No,
you
but
have to resort
can
on.
I answer this question?
Yeah, please.
Since Sunita, all these years, Dr. Mandal for 25 years has been managing
Yeah.
congenital glaucomas without any genetic
Yeah.
tests. So to say now that you're going to wait for your surgery because the genetic test is not available, I don't think it's correct. I mean, you have to
Okay.
go ahead with your surgery, and later on you
I
can
think when you
look
get
for
the genetic testing, Vinay, possibly it will be a better prognosticator that, okay,
Yeah.
we've done this, the best that we
whole
could.
exome sequencing will
But-
take 1 month. That report takes
No, no, that's
almost
what I'm
like 3
saying.
to 4
After
weeks.
surgery also. Once you've done the surgery, and if I have R390H, then I can talk to the parents and say, listen, we've done the best that we could, but don't think that this kid is ever going to be an absolutely normal, or the other side. So maybe the prognostication post-op
Yeah.
could help, but at least for us, we don't wait until
Yes.
we.
That's what actually I think most of us do that we get the result afterwards, and we think about how to counsel the family members or prognosticate and all. But I was in the last session when you mentioned that you already talking about a patient undergoing GAT, and you already knew the gene mutation, and you said that no, I should not be doing GAT here and doing trap and trap.
Yes,
So I
so that
thought
has helped.
that so
That
then
has
in that
helped, yeah.
case, if we get a result prior,
Yeah,
if we are
prior.
doing it,
If we
would
are
be
waiting,
useful,
if
right?
the child has URI, and if it just happens that we have a result before, very good. We
Yeah.
don't do it. Yeah.
So, I mean, if
If
we
I
are
can-
doing the testing, then if it is possible to get the report before it is not too delayed, I think that would be excellent. Of course, it is not mandatory, but then if we are able to do and get the report earlier, I think that can be useful in certain situations.
But even the phenotype would tell you that. You know, with ectropion UVA, you're seeing the angle. Even then, somebody would poke me and say, please, you know.
Yeah, if I can just add, maybe slightly deviating from the congenital glaucoma, but childhood glaucoma per se, one situation where I would wait for the report before I even would touch the eye is this inherited retinal dystrophies with angle closure glaucoma. So there are situations where I've told parents, though the pressures are very high, just hold on, I'm not going to touch this child. Let me first confirm, because if I have to do something like, let's say I have to do a vitrectomy with an IZHV, to me that is a very invasive procedure. If you have to do that, then I would not want to touch that eye before I confirm the diagnosis. So then we confirm the diagnosis, wait for the genetic testing. In fact, we are behind the genetic counselors and try to get the report as early as possible, and then we go ahead and treat.
But
So
you already diagnosed the retinal condition there.
that is true, but then the phenotypes can be so variable. You know, in BEST, you can see the typical kind of subretinal changes that you see, intraretinal cysts that you see and things like that. Sometimes you also see that it's like an atrophic stage. You hardly can make out what is happening. So phenotypes can be very, can be classical, but then can be very deceptive as well. So you would want a genetic testing report before it. At least for me, if you ask me one condition where I will wait and I'm chasing them, it is this.
I think we're off time, 9:30, but would anyone like to take this AI?
So I think in children, we are not using that much of AI. We are using it for adults, you know, diagnosing.
Simple intelligence.
Because diagnostic equipment, because only pressure and fields and all are not so useful, because it's, you know, so many phenotypic variations and all. But hopefully in future, if we can, you know, have the software which can tell us about the risk factors of you know, risk of developing glaucoma in the other eye, as we were discussing in the last session. So I think that would be really useful.
We've already published AI with pediatric corneal disorders. So you know, we've used, this is published recently by the Cornea people, where they've used photographs, UBMs, ASOCT of a large number of patients, did an AI, and then to be able to find out which, using just images, is a corneal dystrophy, which is like a CHED, or which is actually congenital glaucoma. So sometimes on the face of it, it's very difficult to make a diagnosis. So now we're using images and all, UBMs, AIs, ASOCTs, and to diagnose which is which. So but that's only preliminary. So we need to
in fact, Dr. Vinay, I would say that in glaucoma, we have much more parameters where we can use AI more usefully, because we are going to look at corneal diameter, we are going to look at axial length, corneal thickness, intraocular pressure, anterior segment images, disc images, and family history. So the number of variables we have, if we have to train an AI tool to predict or prognosis as well as the diagnosis, it could be very useful. I mean, that's what I was about to refer, that as you have in cornea, there are only images. We have many more parameters, and it can be, any AI model can be easily trained if we have so much of data from all the big institutes, where we have all these, including the genetic testing, now the number of kind of genes that these patients have, the family history that you have, the phenotype that you have. So we can actually get what are the top predictors. So if we have, say, get top 3 predictors, it becomes very easy for us to know, this is what going to work, or this is what it is the phenotype going to be. So I think it is very, very, you know, it would be very, very useful if we work on it.
Yeah, so we did a pilot study, and then we found that AI, if you're looking at, so anterior segment getting images is not easy, because whether it is the magnification, whether it is the amount of illumination, everything matters. So it's not easy to get an appropriate, let's say for example, if you want to get the corneal diameter, it's not easy to get. But as far as the posterior segment fundus images are concerned, with the current available AI, we were able to use that in children. And those with actual disc damage, AI was able to pick up 100%. And when you say that the disc is healthy, but there's enlarged corneal diameter and HAP striae, the AI was saying it is normal. So wherever there are actual disc changes, you are able to pick it up as far as the posterior segment AI is concerned.
Yeah,
yes, it has a lot of promise, and I think we are just preliminary work now.
So that is something similar to adult glaucoma as AI has been working
Yes.
well, so I'm
But
sure
I
in
think we
that.
really need big data for that.
Yes.
And we can all collectively.
Right, we
do it.
we can all come up for a picture because I
Yeah.
think we really need to
Yes.
move up, come up. Everybody can come up for a photograph, please. Oh, photo wale bhaiya hai yahan pe. Thank you.